Dr. Manisha. Sir.
Good morning. At the outset, I'd like to thank Dr. Ajay and AIOS for this opportunity. And it's really good to see so many people attending this early morning session. So I'll be talking about cataract surgery in diabetic retinopathy. How do we optimize the outcomes? As has already been said that diabetes is becoming so very common in India. And we also know that cataract is so much more frequent in diabetics as compared to normal patients. And cataract not only develops more rapidly in diabetics, but it also occurs at a much younger age. And almost 25% of all our cataract surgery patients are diabetics. As has already been said, we need to optimize the diabetic retinopathy, of course. But to optimize the visual outcome, the cataract surgery has to be given special attention in diabetic patients. So what can be the indications for cataract surgery? Either you have an advanced cataract or there's poor visualization, and we know how important it is to monitor the retina. It could be combined with VR surgery, or it could also be an association with glaucoma. The main concerns that we do have in cataract surgery is the post-op CME, worsening of the diabetic macular edema, progression to PDR. As we know, the patients are more, susceptible to increased inflammation, risk of infection, and the surgery itself is definitely more challenging, especially where patients has received multiple intravitreal injections or have had a VR surgery earlier. So managing the comorbidities preoperatively, intra and post-op is extremely important. In the preoperative management, we need to look at the systemic condition of the patient, whether the patient has associated nephropathy, any cardiopathy, neuropathy, vasculopathy, and of course the ocular, anterior-posterior segment needs special attention. A good metabolic control cannot be emphasized enough, and the blood sugar levels, as has been said by AIOS in their handout also, that it should be less than 180 mg%. And we need to look into all the parameters of the patient prior to taking them up for surgery. Here itself, I can show you how a patient who had, center involving diabetic macular edema, just with a good systemic control, the patient was, the retina was well stabilized, and then the cataract surgery was planned at a later date. So it's also important not to, reduce the blood sugar levels very rapidly, as we know that can be, a bit deteriorating to the patient as far as worsening the maculopathy, causing a progression to PDR. So we need to counsel the patients that the blood sugar needs to be controlled, but in a slow manner. So preoperatively, there are very many challenges because of inflammation, ocular surface disease, neovascularization, glaucoma, poor pupil dilation, endothelial dysfunction, zonular instability, and also the cataract may be more difficult. So managing the inflammation preoperatively is very important. As we know, diabetics have a greater level of inflammatory mediators, and we need to start the NSAIDs preoperatively and also continue them much more than we would do in our normal cataract patients. So managing the ocular surface is also very important, as these patients are more prone to hypoesthesia, meibomitis, blepharitis. They could have poor wound healing, and also the unstable tear film, because these patients do have dry eye. That can lead to variable keratometric readings and could affect your biometry. Also look for NVI, and that needs to be managed preoperatively. Look for glaucoma, and your management of cataract depends upon the kind of treatment the patient is on, how well the glaucoma is controlled, the compliance, how much is the advanced glaucoma. And nowadays, of course, we are moving towards MIGS, and that can be well combined with a cataract surgery. Assessing the posterior segment is important not only for the management but medico-legally. So we must document it very carefully, and it also helps to prognosticate and counsel the patient as far as the visual improvement goes. Because for them, a motiabind operation is very simple, and they know that most of their peers, their family recover very good vision after cataract surgery. But the patients who are diabetic, we need to spend a little bit more chair time and counsel them, not only that the surgery itself is going to be challenging, but they also need to continue a very close follow-up with their retina specialist. So sometimes the posterior segment treatment should precede the anterior segment treatment depending upon the visibility. So depending upon the clarity of the lens, we will decide what is the kind of intervention we need, what is the kind of diabetic retinopathy the patient has, and that is going to affect our decision for cataract surgery, whether we want to do an early cataract surgery if the patient is well controlled and has very mild to moderate NPDR, or whether we want to tackle the maculopathy and the PDR first in sequentially, depending on the situation. We also know that even if, despite a very good surgery, there can be a significant increase in the macular thickness despite uncomplicated cataract. And that again we need to look at, because we know that the blood aqueous barrier gets affected in diabetic patients. So intraoperatively, a few comorbidities that maybe need to be tackled with good viscoelastics, having pupillary expanders at your OT facility, having the CTRs available, capsular hooks, and also a backup IOL, especially where you may think that the patient has undergone several injections, the patient has had a vitrectomy, the patient could be having a pre-existing posterior capsular defect. So what kind of lens we would select? First of all, a very careful biometry needs to be done, especially patients who have undergone vitrectomy. And we always prefer a hydrophobic acrylic foldable lens. Heparin-coated lenses are available also, though not as much as they used to be earlier. And the big dilemma is whether we can go for multifocal lenses. I would advise to stay away from them in patients of diabetic retinopathy. But yes, if you have a patient who is, say, in his 70s, he's well controlled, and now you know that, yes, the patient is unlikely to develop diabetic retinopathy, in such cases, you can go in for a multifocal lens, but counsel the patient about contrast sensitivity issues. Avoid using AC IOLs or iris-fixated IOLs where possible, and EDOF lenses, which are the new game changer in cataract surgery, they can be used in well-controlled diabetic patients. So does the diabetic retinopathy increase the incidence of complications? Yes, it does, definitely. And so we cannot take cataract surgery for granted in diabetic patients. We should always try to do it with greater caution, and it should be undertaken by an experienced surgeon. So few intraoperative pearls, you may want to give a block. The rexes should be of very optimum size. That's very important. Protect the endothelium. Avoid hydrodissection in patients which are post-vitrectomy. And the zonules may be weak, so you may need to go in for a CTR. A very meticulous cortical cleanup is important. And the IOL should always preferably be put in the bag. Removing all the visco is also important to avoid any IOP spikes. And in case where you may be thinking of laser or vitrectomy after the cataract surgery, a suture is a must. So the post-op management is important. It should be an aggressive topical steroids. NSAIDs should be continued for much longer. Lubricants are very important because these patients do have disturbed ocular surface. The glaucoma part needs to be followed up regularly. Avoid an early YAG capsulotomy, and do counsel the patient to follow up with their retina consultant. They should not be lost to follow up. That should be very much underlined to the patient. So my take-home message is that the outcome is very good now, provided that the retina part is well looked after. A pre-op fundus examination is a must, and we need to manage the comorbidities before taking up the patient for cataract surgery. So systemically, the patient should be stabilized, the retina should be optimally stabilized before taking up the patient. And managing the macular edema, because we need to differentiate between cystoid macular edema and a diabetic macular edema. That needs to be seen, and we also need to tell the patient that they have to come for frequent post-op follow-ups so that the retina can continue to be stabilized. Thank you so much.
Thank you, Dr. Ritu. I request